A very good morning to all of you. I am Dr. Sabitha Raj, Associate Professor from the Department of Oral Medicine and Radiology. Today's topic for discussion is going to be on odontogenic tumors. We are going to see odontogenic tumors under the following contents. We are going to see the introduction, the classification, and going on to a few of the important odontogenic tumors, which I would be discussing on is going to be on ameloblastomas, adenomatoid odontogenic tumors, calcifying odontogenic tumor, odontomas, and myxomas. So what is an odontogenic tumor? Tumor is nothing but a swelling or a growth that can be seen obviously. It does not depict any of the neoplastic changes. So any growth or a swelling that you can visibly observe is called as a tumor. And if such kind of tumors develop from any of the odontogenic apparatus, either from the epithelium or from the mesenchyme or by the combination of both, it is called as an odontogenic tumor. So any tumor that arises from any of the odontogenic apparatus is what is called as odontogenic tumors. There are a few tumors which do arise from the remnants or from the pre-existing cyst also. Or sometimes these tumors could convert itself into malignancies. Generally, these kind of odontogenic tumors are benign, but sometimes they have the potential to convert itself or get into a malignant condition. But sometimes it remains as an hamartoma. So going on to the classification. According to the World Health Organization, odontogenic tumors are broadly classified into benign and malignant. Under benign, we have the odontogenic tumors arising from the odontogenic epithelium without the odontogenic ectomesenchyme. So they are tumors which develop from the odontogenic epithelium and they are not involving the ectomesenchyme. So the examples being ameloblastomas, squamous odontogenic tumors, calcifying epithelial odontogenic tumors, and adenomatoid odontogenic tumor. We have the second category, the tumors which arise from the odontogenic epithelium with odontogenic ectomesenchyme with or without hard tissue formation. So this is the second category, and the examples being ameloblastic fibroma, ameloblastic fibrodentinoma, ameloblastic fibroodontomas, odontoameloblastomas, calcifying odontogenic cyst, complex odontomas, and compound odontomas. The third category under the benign conditions are the odontogenic tumors arising from the odontogenic ectomesenchyme with or without included odontogenic epithelium. So they are mostly from the odontogenic ectomesenchyme. The examples being odontogenic fibromas, the myxomas, and the cementoblastomas. The second category, as said, are the malignant conditions or the malignant odontogenic tumors. They are classified further into odontogenic carcinomas and odontogenic sarcomas. Examples for odontogenic carcinomas are malignant ameloblastomas, primary intraosseous carcinomas, clear cell odontogenic carcinomas, and ghost cell odontogenic carcinomas. Then we have the odontogenic sarcomas, the example being ameloblastic fibrosarcomas, ameloblastic fibrodentinosarcomas, and ameloblastic fibroodontosaarcomas. So then what is ameloblastoma? So this is the first tumor that we are going to discuss on. This is the second most common tumor of odontogenic tumor. The first common tumor is going to be the odontomas. So it was coined ameloblastoma by Churchill, and before it was called as adenoameloblastoma by Malazes. According to Robinson, ameloblastoma is defined as a tumor of the odontogenic origin which is usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. So this is the definition of ameloblastoma, which says that it is unicentric, develops from one particular aspect. it does not alter any functions as such. It is intermittent in growth. Suddenly there will be a progress of growth, or there may increase in growth, suddenly there will be a slow growth. Anatomically benign, most of the time it is benign, and clinically persistent. We will be able to see it clinically. So going on to the pathogenesis of ameloblastoma. The tumor may be derived from, so these are the things from which ameloblastoma could arise, probably arise. So first thing what they say is going to be, it is going to be developing from the cell rest of the enamel organ, which could either be remnants of the dental lamina or remnants of the epithelial root sheet of malacis. They also say like it could be because of the disturbance in the developing enamel organs or from the basal cells of the surface epithelium of the jaws. There is another kind of an ameloblastoma which develops itself from the heterotopic epithelium from any other parts of the body, especially from the pituitary gland. Then again, there is another area from which it could also develop, which is from the pre-existing odontogenic cysts, especially the dentigerous cyst or the odontomas. So ameloblastomas are broadly classified, or the types of ameloblastoma. There are three types of ameloblastoma. One is called the conventional solid or multicystic ameloblastoma. The second is the unicystic ameloblastoma. The third type is called as the peripheral or the extraosseous ameloblastomas. So here the solid or the multicystic variant accounts to about 86% of all cases. So most of the cases that we are going to deal is going to be about conventional or multicystic ameloblastomas. Whereas 13% of the ameloblastoma accounts to be unicystic. Whereas only 1% of the ameloblastomas accounts to be from the extraosseous type of ameloblastoma, which as said usually develops from the pituitary. So going on to the clinical features of ameloblastoma. So what are the clinical features? Clinical features is like we have to understand how it is represented, whom it is representing, where all it is representing, which is the most predominant area, which is the most predominant age. So generally here the ameloblastomas range between 33 to 39 years of age, or middle-aged people are the ones who are mostly affected by ameloblastoma, which is very rare in children who are younger than 10 years of age. There is no sex predilection, so males and females are equally affected, and the ameloblastoma usually affects the mandible, which is most commonly affected area. About 80% of all cases are going to be in the mandible or the posterior aspect of the mandible, usually the molar ramus area. Then it is the premolar and the anterior regions. So usually it is not associated with pain and paresthesia. As said, it is a benign condition, so that you might have a swelling. Pain will not be associated until and unless it is going to be secondarily infected. So when it's going to be small, or when there are not much of secondary changes, there's not going to be any sort of pain associated with the ameloblastomas. So going on to the radiographic features of ameloblastomas. The most typical radiographic feature, as said by ameloblastoma, is going to be multilocular radiolucent lesion. So what do you understand by the term multilocular? Locules is nothing but you have a radiolucent area which is going to be surrounded by a radiopaque line. So this is one locule. Like that you have multiple locules. This is what is called as multilocular radiolucent lesions. And again, ameloblastomas are typically having two kinds of representation. One is called as the soap bubble appearance and the other is called the honeycomb appearance. When the loculations are small, here you can see small loculations. This is called honeycomb. If the loculations are large, then it is called as soap bubble appearance. So here I think all of us will be able to appreciate that there is a tooth here which has been pushed to the almost towards the ramus area, and this is the loculations that you can appreciate. This is how it is represented. The ameloblastoma is represented as multiloculations or multilocular appearance, which is called as the soap bubble appearance. Again, the most important aspect of ameloblastoma is it produces a buccolingual cortical expansion. Buccolingual in the sense it is able to produce an expansion of the bone, and the roots of the tooth which is adjacent to the tumor will be resorbed, or most of the time the ameloblastomas causes resorption of the roots, which is very evident here in this radiograph. See, here you have the radiolucency, here you have the resorption of the roots in relevance to 3-1 and 4-1. Again, displacement of the teeth would also be associated in the earlier stages. So going on to the histopathology of ameloblastomas. Histologically, ameloblastoma shows neoplastic proliferation from the odontogenic epithelial cells and have a distinct pattern. So there are 5 types histologically classified as ameloblastomas. So they are the follicular type, plexiform type, acanthomatous type, granular type, and basal cell type. And out of this, the follicular and the plexiform patterns are the most common type of ameloblastomas that we can see. So then going on to the treatment. Now that we know the clinical features, radiographic features, and the histological features, we'll have to know how it has to be treated. So going on to the treatment aspect, so whether it is a conventional or a multi-cystic or intraosseous ameloblastomas can be treated by various means. From simple enucleation and curettage to en bloc resection. So simple enucleation is complete removal of the tumor as such, and complete curettage with en bloc resection with giving a clearance of about 1 to 1.5 centimeters. So now that we have finished off with the solid ameloblastomas, let us discuss about unicystic ameloblastoma. So unicystic ameloblastomas are often seen in younger age group. So it is a bit contradictory to the regular ameloblastomas or the solid ameloblastomas. So usually in the second decades of life, but again found in the mandible in the posterior aspect. So here again the lesions are often asymptomatic, but if they become larger, it may cause a painless swelling. So in many patients, the lesion typically appears as a circumscribed radiolucency that surrounds the crown of an unerupted mandibular third molar. So as the word says or suggests unicystic, it is representing itself as a single radiolucent area which is surrounded by a radiopaque border, usually surrounding the crown of an unerupted mandibular third molars. So this is the radiographic feature. This picture shows radiolucency. This is the radiolucency that all of us will be able to appreciate in a 7-year-old boy. We have the displaced tooth here along the inferior border of the mandible. This is the inferior border of the mandible, and the tooth is displaced to the inferior border. And this is thought to be a dentigerous cyst. It could probably be an ameloblastoma also, or a cyst converting itself into an ameloblastoma. So this is the coronal section of the computed tomography, where you will be able to appreciate a radiolucency here, a huge large cystic area, where in between you are able to see a interluminal mass representing a unicystic ameloblastoma. So the cyst would be present here, and it may be converting itself into a ameloblastoma. So again, the treatment of unicystic ameloblastoma is going to be enucleation or complete removal of the tumor. Then as said, we have another entity called the peripheral or the extraosseous ameloblastoma, which I said is going to be mostly associated with the pituitary. So it is very uncommon and accounts to only about 1 to 10% of all the ameloblastomas. And it is thought to rise from the rest of dental lamina beneath the oral mucosa or from the basal epithelial cells of the surface epithelium. So usually presents itself in the gingiva. So it is usually painless and it's non-ulcerated. It could either be sessile or pedunculated, mostly associated with the gingiva or the alveolar mucosal lesion. So it could be ulcerated and painful when it is going to be superadded, or superadded infection is going to be associated with it. So sessile and pedunculated, if it's got a broad base, then it has got to be sessile. If it's got a stalk and then the tumor develops, then it is called pedunculated. So most of the time we may get confused with a pyogenic granuloma, which is predominantly present on the gingivas. The clinical features are non-specific, and most of the time it could be associated or getting confused with fibromas or the pyogenic granulomas. Usually these kind of tumors are smaller than 1.5 centimeters and found on the posterior gingival and the alveolar mucosa. They are also more common in the mandible than in the maxillary areas. Again, the treatment aspect of this is going to be local surgical excision or the complete excision of the ameloblastoma or the tumor. The second tumor that we are going to discuss is going to be called as the adenomatoid odontogenic tumor. Formerly, it was considered as a variant of ameloblastoma and it was called as adenoameloblastomas. But now, because of the clinical, biological and the morphological behavior which is different from that of ameloblastoma, it is considered as a distinct entity. So the tumors, these kind of tumors are derived either from the enamel organ epithelium or from the remnants of the dental lamina. Going on to the clinical features of adenomatoid odontogenic tumors, it is actually quite rare and accounts to about only 1 to 10% of the odontogenic tumors. And it's going to be associated with people around 10 to 19 years of age. It's just opposite to that of ameloblastomas and find twice as often in the maxilla than in the mandible. And again, in the maxilla, it is the anterior part of the jaws which are going to be affected more than the posterior aspect of the jaws. Here it has got a female predilection which is twice as often as that of the males. And most odontogenic tumors are relatively small and do not exceed 3 centimeters in the greatest diameter. So again, it appears as small sessile masses on the facial gingiva of the maxilla, and adenomatoid odontogenic tumors are usually asymptomatic and discovered only during a routine radiographic examination. So if the patient is going to come to us for some other purpose, some other problem associated with the tooth, then when we go in for a routine radiographic examination, we might come across a tumor which may be leading into what is called as the adenomatoid odontogenic tumors, because the large lesion alone causes the expansion of the bone, and when it's going to be very small, there's not going to be any sort of expansion or facial asymmetry that could be identified or noticed by the patient. Going on to the radiographic features of adenomatoid odontogenic tumors. So usually it appears as a circumscribed unilocular radiolucency. Circumscribed will be able to find the margins. Unilocular, only a single locule which involves the crown of the unerupted tooth, and most often it is the canine. As said, the maxillary anterior teeth is the one which is going to be associated with adenomatoid, and most of the time it is the cuspids. And the lesion is usually completely radiolucent. Sometimes it contains snowflake-like calcifications. I think we'll be able to observe that here in this radiograph. Here we have the unilocular radiolucency with an impacted tooth, or the canine here, and then we have the calcification which is going to be associated, which helps us to differentiate from that of a dentigerous cyst. Histopathology, like microscopically, the tumor is going to be composed of spindle-shaped epithelial cells which forms sheath strands in whorled masses of cells in a scanty fibrous stroma. And it has got a tubular, a duct-like structure, which are characteristic feature of adenomatoid odontogenic tumors. And these duct-like structures are bordered on the periphery by large layer of tall columnar cells which resembles ameloblastomas. Again, the treatment here completely benign. Because it is completely benign, enucleation could be easily done, and again it is capsulated and it is not aggressive, hence recurrence is very rare after the enucleation. So here like we'll be able to observe that the entire tumor has been enucleated, and this is the capsule that we can see along with the impacted tooth, and these are the vegetations that we can be seeing or associated, which appears radio opaque in the radiographs. Going on to the next tumor, which is called the calcifying epithelial odontogenic tumor, which was named by Pinberg, and hence it was called Pinberg's tumor also. So this calcifying odontogenic tumor is uncommon lesion which accounts for less than 1% of all odontogenic tumors. So it's just only 1% of all the odontogenic tumors. The tumor cells bear a close morphological resemblance of the cells of the stratum intermedium of the enamel organ and the dental lamina. So going on to the clinical features of calcifying epithelial odontogenic tumors, it usually presents in patients between the age group of 30 to 50 years of age. And most of the time, most of the clinical features are going to correlate with that of the ameloblastomas. Here there's not going to be any sex predilection as similar to that of ameloblastomas. And about 2/3 of all reported cases have been found in the mandible, and if it's in the mandible, it is the posterior aspect of the mandible which is going to be involved. So it causes a painless, slow-growing swelling, which is most common presenting sign. So once it becomes infected, it can cause pain and it can even cause expansion of the bone. When it's small, it does not cause expansion of the bone. So going on to the radiographic features of calcifying epithelial odontogenic tumors, the lesion may be entirely radiolucent, but the defect usually contains some calcified structures of varying size and density. The radiograph shows a tooth which is here, again the radiolucence here, resorption of the root in relation to this particular tooth, and this is the calcification that we can observe surrounding the tooth, which will be helping us to diagnose or identify that it could probably be calcifying epithelial odontogenic tumors. Histopathology, the tumor reveals sheets of closely packed polyhedral cells with non-inflamed connective tissue stroma, and these tumor cells contain oval-shaped nuclei and homogeneous eosinophilic cytoplasm. One of the most important histological features of CEOT is going to be the presence of the calcified masses in and around the tumors. Again, the treatment is conservative local resection to include a narrow rim of the surrounding bones. So usually when there is a tumor and being going for a complete resection, at least 1 to 1.5 centimeters of the margin has to be cleared to prevent further recurrence. Lesion in the posterior maxilla should probably be treated more aggressively. The next tumor that we are going to discuss is going to be the odontomas. So what are odontomas? These are the most common type of the odontogenic tumors. So the most common odontogenic tumors are going to be the odontomas. The second most common odontogenic tumors are going to be the ameloblastomas. So odontomas are considered to be the developmental anomalies or the hamartomas rather than true neoplasm. Hamartomas is nothing but growth of that particular cells in that particular area. So when fully developed, odontomas consist chiefly of the enamel and dentine with variable amounts of pulp and cementum. In the early developmental stages, there are various amounts of proliferating odontogenic epithelium and the mesenchyme which are going to be present. So what are the clinical features of odontomas? These odontomas are subdivided into compound odontomas and complex odontomas. So what are compound and complex odontomas? Compound odontomas are composed of multiple small tooth-like structures. So any mass or tumor which resembles a tooth, which will be multiple, is called as compound odontomas. Whereas if you find a conglomerate mass of enamel and dentine and which bears no anatomical resemblance of tooth, so it's just a mass of enamel or a dentine which appears radio-opaque without the appearance or the morphology of tooth, which is called as a complex odontomas. So occasionally these lesions may show features of both compound and complex odontomes. The clinical features, again, it's going to be appearing in the second decades of life with around 14 years at the time of diagnosis. Usually it is asymptomatic and found in a routine radiographic examination when the patient is going to come to us with some other problem, and when we take in radiographs we might come across some odontomas. Otherwise, when it's going to be small, it is going to be asymptomatic and the patient is not going to come and complain about such things. So size can vary from that of a tooth size to up to 6 centimeters in size, and large lesions can cause jaw expansion. If it's going to be very large, it's going to cause expansion. Otherwise, the patients are not even going to be aware of such kind of tumors that are going to be present. So it is more frequently present in the maxilla than in the mandible, and complex and compound odontomas are found at any site where the compound types are present in the anterior maxilla, whereas the complex odontomas are found in the molar regions of any of the jaw, the maxilla or the mandible. And again, the odontomas will completely develop within the gingival soft tissues. So you cannot see an odontoma outside, so it will be within the gingival soft tissues, and only during routine radiographic examinations we might be able to come across odontomas. So this is how it is. Radiographically, the compound odontoma appears as collection of tooth-like structures. So here we will be able to appreciate that there are collection of tooth-like. This is the small tooth-like structures, or the morphology of the tooth will be present. We will be able to see the radiolucent area, or representing the pulpal region. All that we will be able to appreciate in this kind of odontomes. Whereas in complex odontome, we just find a calcified mass with a radio density, with a radio opacity, which we will be able to find, which is going to be surrounded by a radiolucent line. So here we will not be able to check for, or we'll be observing the morphology of the tooth, or we will not be able to observe the pulpal structures which are going to be present here. So it's just going to be a thick mass of calcified structure that we are going to be able to appreciate in this kind of radiograph. So finally, going on to the treatment of odontomas, it's going to be simple local excision, and the prognosis is going to be extremely good. The last tumor that we are going to discuss is going to be on the odontogenic myxomas. So what are odontogenic myxomas? These are tumors which are believed to rise from the odontogenic ectomesenchyme. And so they have a close microscopic resemblance of the mesenchymal portion of the developing tooth. So all these, while most of the tumors that we had discussed are going to be more towards the epithelial origin. Here it is going to be an ectomesenchymal origin, the odontogenic myxomas. So the clinical features, it's going to be predominantly found in the young adults, but occurs in any age group. The average age for the patients with myxoma is going to be around 25 to 30 years, or the middle-aged or less than middle age. There is no sex predilection, and it is going to be present in the mandible, and if it is more than that, of the maxilla. So again, as said, small tumors are going to be very asymptomatic and discovered only during a routine radiographic examination. Once it becomes large, it could be usually associated with a painless expansion of the involved bone. So only when it becomes large, otherwise there is not even an expansion, and even if there is expansion, most of the time it is going to be painless. And the clinical growth of the tumor may be rapid, which probably relates to the accumulation of the myxoid ground substance in the tumor. So when there is an accumulation, more amount, suddenly the tumor may become rapid in growth because of the accumulation of the myxoid ground substance. The radiographic feature here, the myxomas could appear as unilocular or multilocular radiolucencies. It may cause a displace or resorption of the tooth in that area of the tumor. So usually it represents itself as a soap bubble, as said, multilocular radiolucency, which represents itself as soap bubble, but the typical representing factor here in myxomas is called as the tennis racket appearance. So what is the difference between soap bubble and tennis racket? Here soap bubble, it will have round loculations, whereas in tennis racket we will have a right angle, the stria will be merging at right angles to each other. So it can represent itself as a radiolucency, unilocular radiolucency between the right mandibular, lateral incisor and the cuspid also, or anywhere it could appear as a unilocular radiolucency. But sometimes it can appear as multilocular radiolucency, representing as step ladder pattern, and I think all of you will be able to appreciate that here we have the loculations which meet at right angles to each other. Even here we are able to check this right, and it is not round as in honeycomb or soap bubble appearance, hence it is called tennis racket appearance. And going on to the occlusive view of the large myxoma, it shows buccal expansion. This is the buccal expansion which we are able to appreciate, and here you are able to appreciate the soap bubble appearance also, which is similar to that of ameloblastomas, but here we are able to find the tennis racket appearance. And the gross specimen which shows a gelatinous white mass showing the myxoid tissue. Then going on to the treatment of myxomas, small myxomas are generally treated by curettage, but careful periodic re-evaluation is necessary for at least 5 years. So then again, complete removal of the large tumor by curettage is very difficult, and especially when it is in the posterior maxilla. So then it has to be should be treated more aggressively in the most of the instances. And recurrence rate for most of the studies is going to be approximately 25%, and in spite of the local recurrence, the overall prognosis is going to be good and metastasis do not occur. So the prognosis is going to be good, so, but complete removal and curettage is very, very important for treating myxomas. So before we wind up, I would like to summarize and what we discussed throughout the class. So first we try to go about with the introduction of what odontogenic tumors were. Then we went on with the classification of odontogenic tumors. And then we try to discuss about 5 important odontogenic tumors, starting from ameloblastoma, adenomatoid odontogenic tumors, calcifying epithelial odontogenic tumors, odontomas, and odontogenic myxomas. Thank you.